Okay, so good evening, everyone. Today I'm going to talk about this article named Advances in Multidisciplinary Therapy for Meningiomas. My name is Mariana Holguín Gómez, and I'm from Mexico City. I study at Facultad Mexicana de Medicina, Universidad La Salle, Mexico, and I'm a four-year student. So here's the index we are going to review in this brief 15 minutes, hopefully. First, we're going to talk about the introduction of the article. Then we're going to talk about some surgery and radiation treatment. Then we're going to go to systemic treatment. And finally, some recommendations. So about the article, this article was published in Neuro-Oncology in 2019 by the authors Priscilla K. Brastianos, Evantia Galanis, Nicholas Butowski, et al. So in total, there were 21 authors from the US, Germany, Canada, and the UK. So as introduction, we know that meningiomas are primarily a neurosurgical disease. And while the majority of tumors are histologically classified as benign, the clinical course and impact on patients and caregivers can be far from benign. The first line treatment we know for meningioma is surgery, followed by, in selected cases, fractionated radiation therapy or stereotactic radiosurgery. So the indications for treatment should always be individualized and take into consideration factors such as age, comorbidity, life expectancy, patient preference, histologic grade, molecular factors, tumor location, and extent of resection. Systemic therapy is largely used in higher grade tumors as a last resort once all surgery and radiotherapy options have been exhausted, but typically results in only modest efficacy. And while the majority of meningiomas have excellent long-term control rates, due to their slow growth, clinical series with follow-up in the range of 5 to 10 years carry the risk of underreporting late meningioma recurrences that can occur decades after primary treatment. So this being said, we're going to talk about surgery. So we know that the surgical gold standard for meningioma. Yes.
Can I just make a comment on the last slide?
Yeah, sure.
I just think for perspective, this is very well stated from the paper, but the field of meningioma, there is no proven medical therapy. And there's, a case report here, a case report there, an immunotherapy worked for one patient, but no one has actually shown a medical therapy, which is kind of remarkable because meningiomas are outside the blood-brain barrier. So when we think about like chemotherapies they've tried, like hydroxyurea, there was just trianotecan, I think, just had a big phase 2 trial, and some others, like there really is nothing that treats these tumors once they start growing, aside from surgery and radiation. And the ones that cause real problems are the ones that grow through that. And I think that the second part that you show is also really important because most follow-up, like even in the studies I've done and things, like if you have 5-year follow-up, you're very happy. But the treatment and actual course of meningioma is much longer. So it's different than glioma, where glioblastoma is going to come in, 2 years, everybody's going to die. This is a long-term thing. And so some of the best studies, there's a few from Sweden or from the Scandinavia area. And when you look actually at 25-year follow-up of meningioma patients, even after Simpson grade 1 resection, which you'll get into in a minute, but a complete resection of a grade 1 tumor, the recurrence rate is over 30%. Or like 25 to 30%. So many of the studies that we look at and the feeling that these are all benign is because in most countries and places, people don't have that kind of long-term follow-up. And that's really important as you guys think about interpreting the literature and understanding meningioma in that process. So anyway, carry on. I just wanted to mention that because I think it kind of tempers how you look at a lot of these things. And also for clinical trials, for medical therapy, a lot of those tumors that they've tried them on are very bad tumors. The meningiomas that are really aggressive come back, and maybe you'll get into some of that in this paper here.
Yeah, sure, no problem. Feel free to interrupt me. I think this is the best part of journal clubs, as you mentioned. Okay, so with surgery treatment, we know that the surgical gold standard for meningioma is complete resection of tumor and any involved dural bone. And recognizing that the so-called benign meningioma regrew despite apparently satisfactory surgery made that in 1957, Simpson described a classification system to define the risk of recurrence following surgery alone based on the surgeon's intraoperative assessment of the extent of resection. So this is known as the Simpson grading. I think we almost know it. The Simpson grades of resection are established here with the corresponding WHO grade and the extent of resection. So the first grade, according to the World Health Organization, is defined as gross total resection of tumor, dural attachment, and abnormal bone, defined as a gross total resection. WHO grade 2 says that is gross total resection of tumor, coagulation of dural attachment with the extent of resection of gross total. WHO grade 3 says that it's a gross total resection of tumor without resection or coagulation of dural attachment or extradural extensions, for example, invaded or hyperostotic bone, with also being a gross total resection. WHO grade 4 says that it's a partial resection of tumor with a subtotal resection, and WHO grade 5 is only a biopsy of the tumor, being also subtotal resection.
The one thing on that, I think it's not WHO grade. WHO grading refers to the pathology. So these are the Simpson grades. And the only caveat to keep in mind is when this grading scale was proposed, it was proposed on patients before we had operating microscopes, before, and not nearly the illumination that we have now. So it was much more just the surgeon like looking in with their bare eyes, or maybe some loops. I'm not sure if they even had how they used those back then, but it was very different than if we like do a Simpson 1 resection where, you know, I'm saying, oh, it's Simpson 2 or Simpson 3 because I leave like a tiny margin or something. Also in meningioma surgery, we don't routinely check margins. When you do cancer therapy, you go to the edge of the dura or something, you check a margin and say, are there cells here? We don't do that in meningioma surgery. So, and that's not incorporated in any of this. So it's all assuming based off kind of your gross looking. And some of this gets debated over the years because people don't know, because we just don't know. It's like, well, I left a little bit there or not, and we never checked it with pathology. We didn't send margins. So there is some ambiguity in this. But the goal is the more complete you can get holds true. But this is Simpson grade, not WHO grade.
Okay, sure. Considering technical things and strategies in meningioma, first, we have to make a meticulous pre-surgical planning with careful attention to neurovascular anatomy, because as we know, there are a lot of blood vessels in the brain and in the meninges and surrounding all of these structures. So it has to be made a pre-surgical planning so the surgery can be successful. Talking about radiotherapy or SRS, an alternative strategy is to leave meningioma invading the sinus that can be monitored or treated with adjuvant radiotherapy or SRS. And talking about image gating, we know that the use of intraoperative MRI and CT can be used to update neuronavigation and identify residual tumor. And some of other advances that have been made with image guiding, it's dotatate PET, which can discriminate between meningioma and normal tissues with greater sensitivity than MRI. And it may be particularly useful for meningioma with intraosseous involvement. And it may also be used as a predictor of tumor growth rate. And also an intraoperative imaging can be used for emerging approaches, such as adaptive hybrid surgery, whereby the surgeon plans to leave a small, deemed unresectable residual that can be treated with postoperative SRS. And finally, for recurrent meningioma, we know that in patients in this situation, the surgical challenges are compounded by scar tissue, and also the underlying brain is more friable and susceptible to injury. So the indications for further surgery, including symptomatic meningioma growth and reduction of the tumor to leave a smaller target for postoperative radiation.
Anna, sorry to interrupt. I just had a question for Dr. Magill.
Yeah, sure.
So Dr. Magill, when it comes to, I guess, neuronavigation with meningiomas, when do you typically use neuronavigation in meningioma resection would you use it for like a meningioma that's located perhaps maybe on the frontal lobe versus something that's more on the base of the brain?
So just cost is not a consideration in where I'm practicing, just because we have an international audience. I know that changes, but I use it every case because I want to tailor my craniotomy. I want to take, even if it's just a convexity meningioma, I can tailor exactly what I want, put things right on it. I think it's a great help and adjunct. Just otherwise, you don't have to do quite as big. You know right where the edge of the sagittal sinus is. You can avoid complications. So I use imaging for every case.
Thank you.
Okay, so moving to radiation therapy. Radiation therapy technique is individualized and depends on meningioma size, proximity to critical structures, and any prior radiation to the same site. And we also have to mention that radiotherapeutic options for meningioma are diverse, and there are no randomized trials comparing different radiotherapy modalities. So excellent control has been observed following various forms of radiotherapy for meningioma, which include fractionated external beam radiation therapy, stereotactic radiosurgery, and finally, brachytherapy. So we're going to talk about some of the radiotherapy outcomes. The first one is radiation therapy following subtotal resection. So it has been seen that the rate of meningioma recurrence following subtotal resection is higher than with a gross total resection. So several retrospective studies have found high rates of local control in patients treated with EBRT following subtotal resection. And in primary external beam radiation therapy, this one is useful for certain tumor locations where gross total resection is not possible without causing significant morbidity to the patient, which I think is very important. Talking about stereotactic radiosurgery and fractionated stereotactic radiosurgery outcomes, we have seen that single fraction stereotactic radiosurgery is generally considered feasible for tumors less than 3 or 4 centimeters in diameter with at least 2 millimeters of separation from critical normal structures. And even though most meningiomas do not shrink significantly after treatment, symptomatic improvement can occur. Then talking about brachytherapy, there are limited options for patients with recurrent atypical or anaplastic meningiomas after prior radiation therapy to the same site. So resection followed by permanent seed low dose rate brachytherapy is a viable salvage treatment option in this patient population, but relatively high complications rates have been observed. And finally, to talk about radionuclide therapy, it has been seen that peptide receptor radionuclide therapy may be beneficial for pre-treated progressive meningiomas. And more specifically, somatostatin receptor type 2A is a highly specific marker for meningioma cells that is not otherwise expressed in the central nervous system, with the exception of the pituitary gland. So meningiomas with higher somatostatin receptor type 2A expression are associated with trace uptake and clinical response. So I don't know if you, Dr. Magill, want to say something about radiotherapy outcomes before we pass to systemic therapy.
I think radiation is very effective. Classic location where you would do primary radiation is a cavernous sinus meningioma. Morbidity of that operation is really high, but it's still I would say in the optimal treatment, surgery, then radiation, and then other things. Brachytherapy is rarely used, but there are times, when you've got these multiply recurrent ones, but in general, thinking about meningioma, it's not like the first thing that comes to your mind. And same with like the luteolide, this is luteolide or whatever you say, luteolide 177 radio tracer. They go with the somatostatin receptor analog, same as like dotatate concept. It goes there. Dotatate just shows you where it is. Lu brings radiation there. No, I think that's good. We should carry on because of the time, and then we can talk some more at the end.
Yeah, sure. Okay, now we're going to talk about systemic therapy. Systemic therapy is very extensive, so I'm trying just to talk about the important points. So what we know is that to date, the efficacy of systemic agents has been disappointing. And patients with meningiomas in surgically challenging areas, such as the skull base, or patients with progressive or recurrent meningiomas after having undergone all potential surgical and radiotherapeutic treatment options, may benefit from systemic treatment options. However, as I already said, the efficacy of systemic agents has been disappointing. And what has been made are advances in chemotherapy, molecular therapy, and immunotherapy. So for chemotherapy, we know some things about trabectedin, and trabectedin is a chemotherapeutic agent which is routinely used for advanced sarcoma and ovarian cancer. And this has shown activity in vitro studies of meningioma, yet its action mechanism is not completely understood. For molecular therapy, we have some specific gene alterations in meningiomas that have been studied. So the main three ones are inactivation of the tumor suppressor gene of neurofibromatosis 2, and this was established as a driver in about 50% of sporadic meningiomas. Then we have the Merlin gene that plays a role in the activation of mTOR pathway during the pathogenesis of meningioma. And consistently, overexpression of mTORC1 pathway components has been reported in meningiomas. Finally, focal adhesion kinase inhibition may be another promising avenue in NF2 altered tumors. Moving to molecular targets, we have some frequent mutations in meningiomas, being, for example, POLR21A mutations that are seen in WHO grade 1 meningiomas. Then we have the ubiquitin ligase tumor necrosis factor receptor associated factor 7, TRAF7, that is mutated in approximately 20% of WHO grades 1 and 2 meningiomas. We have also seen mutations in the Kruper-like factor 4, KLF4 gene, which are exclusively seen in secretory meningiomas. And finally, we have also seen telomerase reverse transcriptase or third promoter mutations which are associated with aggressive meningiomas. And finally, with immunotherapy, what's new is that the expression of programmed death ligand 1, PDL1, was increased in WHO grade 3 meningiomas. So this being said, it has been seen that higher numbers of PDL1 expressing cells have been associated with a worse overall survival. So an immunosuppressive microenvironment might contribute to the malignant phenotype of meningiomas, and this is what has been made for immunotherapy advances. So finally, talking about some recommendations. First of all, patients should be made aware of all possible treatment options for primary and recurrent disease. And challenging cases and multiply recurrent cases should be reviewed with a multidisciplinary team. Development of a core outcome set that includes intervention complication rates, epilepsy, cognitive function, and health-related quality of life will ensure that meningioma trials report outcomes that are relevant and important to both patients and clinicians. And clinical trials should continue to stratify patients according to relevant biological subtypes of meningiomas defined by mutational and epigenetic alterations. And finally, rapid cycle translation from discovery and preclinical testing to clinical trials is needed to promote research on therapeutic advances in meningiomas. And that's about it. So if someone wants the article, just feel free to email me, and I should be able to share it with you. Thank you for your attention.
That was excellent. A big overview.
All right, Collins, if you want to go ahead with your slide, Collins and Brittany. Any questions from the audience while they're pulling up their slides on Mariana's talk? All right, looks like you're good, Mariana.
Can everybody see it in full screen?
No.
Just a moment. Can you see in full screen now?
Still no.
Okay, just a moment.
Now we can.
Are you in Brittany, France?
We colleagues, Dr. Magill.
We didn't know each other. We were just Zooming to collaborate.
Yeah, they became friends from this journal.
Oh, Brittany. I thought you said the country of Brittany is where you were.
Oh, no.
I was looking up like, where is Brittany? I think I know where that is. I think I've heard of it, but it's out on the tip of France. So I see now. You are in Finland.
Yeah. Excuse me. Can you see the full screen now?
No, we initially did, but now it's back to, we're just seeing like a panel and the slideshow.
Just a moment.
Now we can.
Yep.
Well, not anymore. We could prior, but it's back to the same.
One moment. I'm so sorry.
It's okay.
So you probably see the whole screen.
No,
And,
no. Is everyone able to see his slides?
They're too tiny.
Yeah.
can you see it now?
No, it just got even smaller.
You're
Brittany,
you're
do you
in.
have
We're
the
seeing the
slides?
presenter side.
Yeah, there we
you
go.
That's it.
Okay. Brittany, do you have the slides? Are you able to share instead?
Yeah.
All right. Brittany can share the slides and.
Yes, it's interesting because
Yeah, you shared it a few moments ago. I'm not sure exactly what's going on.
Looks good.
Yep, looks good.
Okay. So our paper is a molecularly integrated grade for meningioma, which was published just a few months ago in Neuro-Oncology.
Yes, and
I'm Brittany Stope. I'm a third year at Virginia Tech, and
I'm Colin Harnum from Finland, and I attended University of Helsinki, University of South Alabama, and if Brittany, if you can go to first slides to the very beginning. To the very beginning, Brittany. To the first slide, yes. And to the first slide, to the very first slide, to introduction page. Yes, and I went to University of Medicine, Medicine Pharmacy of Craiova in Romania. And as I said, I'm from Finland. And I'm very excited to be here. And as Brittany said, we have a presentation on molecular integrated grades for meningioma. And if Brittany, you can go to the next slide. Yes, so we have abstract key points on aggressive meningiomas have recurrent chromosomal copy number alterations, and integrate this knowledge into grading scheme, basically identifies high-risk tumors. Brittany, could you go to the next slide? Thank you. And we have abstract overview. In a nutshell, it's very common in adults. World Health Organization grading system unfortunately fails to identify high-risk tumors. And we're going to go over integrated grades 1 to 3. And 32% of meningiomas reclassified to lower or higher risks. More accurate identification of meningiomas patients at risk for tumors recurrence despite complete tumor resection will be, we'll discuss over it. Brittany, would you go to the next slide? Thank you. So basically, a quick overview of abstract in building models used in integrated grades 1 to 3. We have a Cox proportional hazard, basically investigating patient survival time with other variables, a random survival forest, a time to event analysis, rate boosting, discovery cohort, 2 independent cohorts of 172 patients, and characterized and orthogonal genomic platform. Brittany, could you go to the next slide? Thank you. So now we have a method. 35,000 new meningioma cases are identified throughout the year. Actually means it's 1 per 100 adults, and approximately within the age range of 4 to 5 years old. According to World Health Organization, grades 1 to 3 based on histopathology. Unfortunately, And the behavior of some meningiomas does not comply with the WHO grades. And the benign meningiomas, in accordance to aggressive treatment, lead to repeated recurrence. And the high-grade meningiomas with a collaboration with surgical resection leads to remain stable. And copy number variation are, in that conclusion, more accurate and luckily broadly accessible. And we're going to go to this next one. Thank you. And methods of these patients were used discovery cohorts of examination of 527 meningiomas in Brigham and Women's Hospital, 2003 to 2019. 81% were analyzed, and independent validation cohort of 117 patients of Brigham and Women's Hospital, and then external validation cohorts were also used in 55 University of Toronto patients. Could you go to the next one? And then, of course, we have a clinical annotation of the methods, assessment of clinical history, assessment of tumor location, and assessment of radiographic recurrence. And of course, the preoperative and the postoperative MRIs were analyzed in accordance to radiologic assessment of meningiomas treatment response, gross total resection, and subtotal resection criteria as a complete response or partial response, stable disease, or progression. Brittany, could you go to the next one? Fantastic, thank you. So methods in clinical annotation, anatomical location of meningiomas, basically midline skull base, lateral skull base, lateral convexity, false percygittal, as you can see in the second picture, and the interventricular and spinal. The next slide will show it a little bit better. Brittany, could you proceed to the next slide? Thank you so much. So as you can see, midline skull base on our upper left, and lateral convexity, and lateral skull base, and interventricular, spinal, and full seam. Brittany, could you proceed to the next one?
Great. So continuing on the methods, the pathology was performed by a board-certified neuropathologist, and the tumor grade was assigned based on the WHO classification of tumors that was applicable at the time that the patient presented. However, if the grade was unclear, then the case was re-reviewed with the current guidelines. Cases where there was brain invasion were graded as grade 2, and this also looked at additional features, including mitoses and MIB proliferative index. So importantly, for the genomic characterization, they used two methods. One, for whole genome microarray analysis, they used DNA copy number profiling, and you can see how many patients this was available for. And then they used OncoPanel as well for the targeted mutation and profiling of specific cancer-associated genes. Now for the model design, which is the crux of what this paper is trying to develop. So first, they excluded the confounding variables by first modeling recurrence in 338 patients who had primary untreated meningiomas with gross total resection. They then looked at covariates that included first the WHO grading elements, which are mitotic index, atypical features, and brain invasion. And then they added three other elements, which is the MIB proliferative index, the chromosome area level, and the CDKNA copy number variations. Each covariate was evaluated for its individual time to recurrence using log rank testing. Those that ranked high were chosen for the integrated grading scheme, and these features were added sequentially to the grade until the addition of no more features would improve the model performance, and that model performance was assessed by the Breyer score. For validating the model, the integrated grade was first compared to WHO grade for predicting tumor recurrence. They did this in three ways. First with the receiver operating curves, next with the average precision curves, and third with the Breyer curves. Then they did internal validation. They cross-validated in the discovery cohort using 10,000 bootstrapped resampling and leave one out cross-validation methods. Then they did external validation in 2 independent cohorts. And then finally, they produced the nomogram, and this would predict recurrence risk. This was derived from the entire discovery cohort using 4 variables: integrated grade, extent of resection, tumor size, and tumor status. And ultimately, the clinical utility of the nomogram was evaluated with a decision curve analysis.
Fantastic, thank you. Well, here we have a study overview of a description of patient cohorts, meningiomas, and of course, as you can see, we have a discovery of 527 patients in a primary tumor costal section with no radiation history, and we have two cohorts of 172 patients of independent validation and external validation, and finally we have cohorts of methylation RNA sequence patients. And Brittany, could you go to the next slide? Thank you. So we have a result of a discovery cohort of 527 meningiomas. Basically, 326 patients were classified according to WHO grading as 1, and 172 WHO 172 patients were classified according to World Health Organization as grade 2, and 29 patients were classified according to World Health Organization grading as 3. And mainly, there were 67% of females, and mean average age was 57. So unfortunately, throughout 43 months follow-up, had 132 recurrences, 27% of tumors didn't have copy number variation, and 18% of tumors had monosomy 22. Brittany, could you go to the next slide? Thank you, Brittany. So we have a result of chromosomal loss and gain, as you can see here. And on the very upper, we have a loss of chromosomes of 36%, 19 to 10%, and a gain of chromosomes from 18 to 6%. Brittany, could you go to the next slide? Thank you so much. Yes, thank you, Brittany. So results in development of molecular-based integrated grades accounts for 1 point, including a focal homozygous and homozygous loss of CDKNSA. Basically, it's a tumor suppressor protein, mitotic count 4 to 19, loss of high-risk short or long arm chromosomes 4, 6, 10, 18, 19, or loss of short or long arm. And 2 points for mitotic count if it's over 20, and tumor divided into 3 integrated grades, 0.0 to 1 points if it's integrated grade 1, 2 to 3 points if it's integrated grade 2, and over 4 points if it's integrated grade 3. Brittany, could you be so kind and go to the next slide? Thank you. And then we have a result association between WHO grades and integrated grades. Now, it's very interesting because World Health Organization grade 2 is actually leads to 32% of cases were reclassified into integrated grade 1, 2, and 3. So WHO grade 3 reboid meningiomas are reclassified into lower risk, of which 33% integrated into grade 1 and 44% integrated in grade 2. And WHO grade 3 and the classic meningiomas, of which 95% remain in integrated grade 3. So concordance actually is very interesting. It's very important because between WHO integrated grades of 127 meningiomas, World Health Organization grade 1 had a concordance of 87% with integrated grade 1, and World Health Organization grade 2 had concordance only 31% with integrated grade 2, and the World Health Organization grade 3 had 72% of concordance with integrated grade 3. And Brittany, would you so kind of go to the next one? Thank you. And then I quickly overview the graphs and results. Basically, we have integrated grades and clinical outcomes. Here we have, as you can see, basically a progression of a free survival rate. The higher the rates, the more probability of occurrence. In a nutshell, so tumor of 338 non-integrated DTR meningioma is demonstrated, and we can see clearly the differences at the upper row, and then in the middle row, we can see the application of integrated grades for the differential recurrence was in grade 1 and 2. And as I said previously, progression of free survival actually indicates the higher recurrence rates. And at the bottom row, we can see WHO grade 1 meningiomas designed into grade 2 and 3 succeeded worse than WHO grade 2 and 3. Basically, what we already discussed. Brittany, could you be so kind and go to the next one? Thank you. So here we have integrated grade predicts recurrence more reliably, and the meningiomas of brain invasion integrated grade 1 succeeded better than integrated grade 2 and 3. And taken together, the integrated grading schemes significantly improved the ability to predict recurrence risk compared to WHO grades. And at the lower bottom, as you can see, lower row, integrated grade continued to outperform the WHO grades in predicting recurrence. Brittany, could you go to the next one? Thank you. And the presence of 1P loss as a single feature confers significantly high risk of recurrence compared to the tumors with intact 1P, as you can see. And of the 244 patients available, mutational data for therapy coverage of the integrated grades outperformed the new 2021 WHO grading scheme. And at the lower row, you can see that integrated grade was superior to WHO grades in the prediction of recurrence. And I think that's simplifies and finalize the whole idea of the research. And I think, Brittany, you're next.
Great. So when they look at mutations, they found that 4 mutations specifically were associated with more aggressive tumor behavior. One of those was the TERT promoter, which was found in 6 patients. Now, among those 6 patients, 3 recurred and 3 did not. And importantly, the 3 that recurred were all integrated grades 2 and 3. The 3 that did not were integrated grade 1, which points to some of the clinical significance of using this grading scheme. Impact of treatment. So gross total resection, you can see on this top row, it did decrease the recurrence risk, but only for integrated grades 1 and 2. It did not delay recurrence if it was integrated grade 3. And so that can help with predicting how to treat patients. Here in the middle, we see that the adjuvant radiation did not delay recurrence in these de novo high-grade meningiomas, whether you use the WHO or integrated scheme. And intuitively, recurrent tumors were more likely to recur. Now, this is really the main finding that they have is the multivariate risk model. So here on the left, we see the 4 variables that were associated with increased risk. So integrated grade had the highest power and the most significance. Also associated were extent of resection, tumor volume, and tumor status. Importantly, some variables that were previously thought to be related were not found to be significant here, including age, male sex, and location of tumor. Now, on the right, you see the calculator, and they validated this as well, and this could be clinically employed as a calculator or a nomogram. So overall, what we found here, the research proposes an alternative to the WHO grading scheme for meningioma, and it improves the accuracy by predicting tumor behavior using mitotic index and copy number profiling. And this integrated grade varied from the WHO grade in about a third of patients. And some of the clinical applications of their findings is that, for instance, you could defer the use of radiation in integrated grade 1 patients. You should follow closely integrated grade 1 patients that have high copy number variations, whether or not they have atypical features, because they're more likely to recur. And complete excision would provide the best long-term progression-free outcome in integrated grade 1 meningiomas. This is our reference, and thank you for your attention.
Thank you, Brittany, for your time, and thank you everyone for attending.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.